Right now, there is an algorithm sitting on a server somewhere that is statistically way more likely to catch your cancer than the human doctor you're going to see next week.
Yeah, which is a wild thing to think about.
It really is. I mean, this thing has read every medical journal ever published. It's processed millions of patient files. It doesn't get tired. It doesn't need coffee, and it never forgets a single detail.
Right.
And yet your local hospital is actively refusing to use it. So welcome to our deep dive into the source material. We are unpacking a massive paradox in modern medicine today.
We really are. The technology to practically eliminate diagnostic error has, well, it's fundamentally arrived.
Yes.
But the healthcare system has built this absolute fortress to keep it out.
And we're pulling from a really fascinating stack of intel today to figure out exactly why. We've got internal strategic assessments, the 2026 Stanford and Harvard State of Clinical AI report, a really detailed clinical intelligence dossier, and this landmark April 2026 study published in the journal Science.
It's a lot of ground to cover.
It is. Our mission here is to break down why this life-saving tech is being sidelined. We want to look at the bizarre systemic walls blocking it and, what this actually means for you the next time you find yourself sitting in a paper gown in an exam room. So, okay, let's unpack this.
Yeah, let's do it. And I think we really need to ground this in the reality of human performance first. Like, to understand why an AI intervention is so desperately needed, you have to look at the baseline.
Right, the baseline of human failure, essentially.
Exactly. There is this baseline of failure that the medical community really doesn't like to broadcast. A 2023 Johns Hopkins and BMJ quality and safety study quantified it, and they literally refer to it as a silent epidemic.
A silent epidemic, that's pretty heavy.
It is. The data shows that roughly 800,000 Americans are killed or seriously disabled every single year, just due to diagnostic errors.
800,000. I mean, that's the population of a major city, just wiped out or permanently harmed annually. And that's just from someone misinterpreting a symptom or reading a chart wrong.
Yeah. And these aren't obscure, 1 in a million diseases either. The research shows these errors are highly concentrated in what they call the Big Five.
Okay, what are the Big Five?
We're talking about cancer, vascular events like strokes, infections, thrombosis, which are blood clots, and heart failure.
Wow.
Yeah, these are the heavy hitters where your margin for error is effectively zero. And the most agonizing part of the Johns Hopkins data is their conclusion. They found that 2 out of 3 of these casualties are completely preventable.
2 out of 3. But, doctors go through a decade of brutal training. This isn't a lack of talent or intelligence.
No, absolutely not.
It just feels like we are hitting the biological limits of the human brain. Like medicine has just become entirely too complex for one person to hold in their head.
That is the exact mechanism driving the failure rate. It's just an unsustainable cognitive load. I mean, the American College of Radiology and the AAMC, they project a deficit of over 141,000 physicians by 2028.
That's a massive shortage.
It's huge. So you have fewer doctors managing infinitely more complex data. If you look at the 2026 PubMed data on radiology, there is a massive, highly quantifiable spike in diagnostic errors at the end of long shifts.
Right, because a human doctor gets tired at 3 a.m.
Exactly. Their eyes just glaze over on their 100th scan of the night. But an algorithm's baseline performance, it never degrades.
Which brings us to this massive April 2026 study from Harvard Medical School and Beth Israel, because they decided to stop theorizing and actually put the OpenAI O1 model head-to-head against 2 highly experienced emergency room physicians.
Yeah, they really put it to the test.
They did. And in primary triage, just figuring out who needs what, immediately the AI hit a 67.1% accuracy rate. Dr. 1 was at 55.3% and Dr. 2 was at 50%. It was a complete blowout.
And, the disparity gets even wider when you move past that basic triage into the truly baffling cases.
Oh, right, the complex ones.
Yeah. The researchers took the gold standard complex clinical cases from the New England Journal of Medicine. These are the ones specifically designed to stump the brightest minds in medicine.
The ultimate test.
Exactly. And the AI provided a highly useful differential diagnosis 97.9% of the time.
That is almost perfect. And there's this one micro case in the clinical dossier that I think really illustrates how this actually works in practice.
Oh, the lupus patient.
Yes, the lupus patient. So a patient came in with rapidly declining health after a previous totally unrelated treatment. The human doctors were completely stumped because the symptoms were just scattered everywhere.
Right, making no obvious sense.
Exactly. But the AI system synthesized years of raw patient history and accurately identified lupus with heart inflammation. It literally connected a blood test from 3 years ago with a vague nurse's note from 6 months ago and then tied it to the current cardiac symptoms.
Which is incredible.
It is, because a human doctor in a chaotic ER physically does not have the time to read through 400 pages of historical PDFs to find those three hidden puzzle pieces.
And what's fascinating here is the mechanics of how the AI actually processes that information. It uses something called vector embeddings.
Okay, break that down for us.
So instead of just doing a basic keyword search for the word lupus, it maps out the mathematical relationship between thousands of seemingly unrelated medical concepts.
Oh, I see.
Yeah, it recognizes the broader pattern of the disease, even when the data points are separated by years of completely unrelated medical history.
But, okay, I've got to push back on this a little bit because there's usually a massive caveat with these tech demos. AI tests are famously run on perfectly clean, idealized lab data.
That's true, usually.
Right, like they train them on beautifully formatted spreadsheets where everything is spelled correctly. But real medical records are a total disaster of bad handwriting, typos, and weird formatting. So how does it handle that?
Well, here's where it gets really interesting. The researchers knew that exact criticism was coming, which is why this 2026 science study is such a landmark moment. They didn't use sanitized lab data.
Oh, really?
No, they deliberately used what the industry calls dirty data.
So actual ER records.
Chaotic, messy, real-world ER records. We are talking about wildly incomplete patient histories, contradictory symptoms jotted down by 3 different nurses over a 12-hour shift, and completely non-standard medical abbreviations.
The kind of abbreviations that change depending on which doctor was on call that night.
Exactly. And the AI proved it can handle the noise of an actual functioning hospital. It weighs the probabilities of contradictory notes and filters out the irrelevant noise way better than a fatigued human trying to decipher medical shorthand.
Wow.
Yeah, Dr. Adam Rodman from Beth Israel bluntly stated that these results easily cross the threshold to warrant immediate, real-world clinical testing.
So the technology works. It thrives in the chaos. It catches the lupus that stumped the human specialists. The obvious question you have to ask is, why isn't this running on every hospital computer in the country right now?
It's the multi-billion-dollar question.
Yeah, right. And the dossiers outline what they call the 3 invisible walls of medical adoption. And looking at the timeline, it is incredibly frustrating. Like, look at Google Health.
Oh yeah, the breast cancer study.
Yeah, back in December 2019, they published a Nature study proving their AI reduced missed breast cancer tumors by 9.4%. But it took until 2025 for a system like Sutter Health in California to actually deploy it at scale. 6 years of waiting.
It's a massive lag.
It is. And when they finally turned it on, they processed 35,000 mammograms in a single quarter, and their cancer detection rate jumped from 4.8 to over 6 cases per thousand. Thousands of women saved. So what took 6 years?
Well, the first of those invisible walls is the regulatory chokehold. The FDA is structurally incapable of evaluating modern artificial intelligence. We have a fundamental mismatch in velocity here.
What do you mean by velocity in this context?
I mean that a neural network can iterate and improve its logic in a matter of days. But the FDA evaluation process takes years. They are applying a regulatory framework built in the 20th century for physical medical devices to rapidly evolving living code.
Right, like trying to evaluate a titanium scalpel or a pacemaker. It's like demanding a 10-year physical crash test rating for a Microsoft Word update. You just cannot regulate a probabilistically shifting algorithm the same way you regulate surgical steel.
Exactly. But because any software that influences a clinical decision is legally classified as a medical device, the developers are forced into years of trials.
And millions of dollars in compliance costs?
Millions. All before a doctor is legally allowed to even look at the output. The innovation bottleneck is immense. By 2025, there were thousands of viable, life-saving AI tools functioning in labs, but only a few dozen had successfully navigated the FDA labyrinth.
And even if a tool somehow survives the FDA, it crashes directly into wall number 2, which is the economics of the American hospital, specifically the fee-for-service conflict.
This is a huge one.
Yeah. According to a really blunt April 2026 analysis by the Healthcare Financial Management Association, an accurate AI actively destroys hospital profitability.
Because we are still trapped in a fee-for-service model, hospitals generate their revenue based on volume. Every exploratory scan, every specialist consultation, every follow-up blood test, those are all billable events.
Yeah.
That chain of events is the financial lifeblood of the institution.
Meaning a perfect diagnosis on day one is basically a CFO's worst nightmare.
It instantly vaporizes the entire billing cascade. If the AI looks at the initial ER data and correctly identifies the obscure condition within 5 seconds, the hospital loses the revenue from the 3 extra MRI scans and the 4 specialist visits a human doctor would have ordered.
Just to narrow down the possibilities.
Right. So from a purely financial perspective, this miraculous efficient technology is actively cannibalizing their bottom line.
The incentives are just so deeply misaligned, we are financially rewarding the long, slow, inaccurate human guessing game. Which brings us to the third wall, the liability vacuum.
The legal side of this is a mess.
It is. If we finally get the tech past the FDA and a hospital actually agrees to take a financial hit and buy it, who goes to jail when it makes a mistake? The legal framework essentially turns the human doctor into a human shield for the tech companies.
That's a great way to put it.
It's like a hospital forcing a paramedic to use a highly advanced experimental GPS to drive an ambulance. If the GPS glitches and tells the driver to turn into oncoming traffic, the software company points to their terms of service and says, well, not our problem. And the paramedic loses their medical license.
Because the legal concept right now is that the human physician is always the final clinical decision maker. If we connect this to the bigger picture, hospitals are forcing physicians to take total personal legal responsibility for a black box algorithm.
A black box they don't even fully understand.
Right. The doctor didn't write the code. They don't understand the neural weights of the AI's decision-making process, but they hold 100% of the malpractice risk. If the AI hallucinated and the doctor followed it, the doctor is sued.
But the trap closes both ways. If the AI suggests a highly unlikely diagnosis, and the doctor ignores it, relying on their 20 years of experience, and the AI turns out to be right.
Then the doctor is sued for negligence.
Exactly.
The plaintiff's attorney will argue the doctor willfully ignored a statistically superior diagnostic prompt. It is a complete no-win scenario for the physician.
The system penalizes the exact efficiency the AI brings. The regulators freeze it, the accountants lose money on it, and the doctors are terrified of going to court over it.
And that legal terror actually leads us into a totally different problem. Let's assume for a second we wave a magic wand.
Okay, one waved.
The FDA clears it, the hospital pays for it, the lawyers figure it out, the tech is finally sitting on the desk.
No.
Now we run into the psychological collision between a human being and a machine.
Oh, this is the automation bias stuff.
Yes. The sources detail this massive cognitive trap called automation bias, which was highlighted in a 2024 Harvard Medical School study.
Huh.
Because doctors aren't just logic processors, They are humans susceptible to suggestion. The Harvard study reveals the dark side of cognitive offloading. They found that when a doctor is paired with a highly accurate AI, the combined performance is phenomenal.
Makes sense.
But the researchers introduced a bad AI into the test, an algorithm mathematically tweaked to confidently deliver the wrong answer.
Oh, wow.
Yeah. And when the human doctors were paired with this confident, incorrect machine, their diagnostic accuracy dropped significantly below their normal solo baseline.
Wait, they stopped trusting their own medical degree?
They completely deferred to the perceived authority of the machine. Think about it. If you have a radiologist at the end of a grueling 12-hour shift and an authoritative AI prompt pops up on the screen declaring, "No tumor detected in this scan," the natural human doubt vanishes.
They're exhausted. The machine is confident.
Exactly. So they just hit approve. They abdicate their critical judgment to the system.
But I struggle with the bias argument a bit, particularly when we look at the systemic level, because the sources pull up this April 2025 study from UCSF analyzing 1.7 million AI diagnostic responses.
The algorithmic bias study, yeah.
Right. And it showed the AI was routinely giving Black patients less aggressive cancer treatment recommendations compared to white patients with identical symptoms. It also gave women vaguer, less detailed cardiovascular explanations than it gave to men.
Which is deeply concerning.
It is. But here is my pushback. If an algorithm is just statistical math mapping out vectors, how can it be prejudiced? If we aggressively scrub the historical data to make it socially fair, aren't we just blinding the AI to real biological demographic differences in how diseases present? How do we fix the bias without breaking the medical accuracy?
Well, it is entirely an engineering problem, not a moral failing of the code. The AI does not possess personal animus. Like you said, it is a statistical mirror.
Okay.
What it has is an insatiable appetite for data, and it trains on vast oceans of historical medical records. And those historical records contain decades of systemic human bias.
Oh, I see.
For generations, marginalized groups have been systematically underdiagnosed. Women's cardiac pain has historically been dismissed or attributed to anxiety in clinical settings.
So the math is just doing its job. It's finding the historical average.
Exactly. It absorbs millions of those historical interactions and learns that this undertreatment is the correct standard of care. It perfectly and flawlessly scales our worst historical habits.
That is terrifying.
It is. And this raises an important question. If the AI is mathematically bound to replicate the data it is fed, fixing the bias requires researchers to artificially alter the weights of the historical data.
But as I pointed out earlier, overcorrecting that data risks masking genuine biological variations.
Right. It risks masking real differences in disease presentation. It is a massive algorithmic tightrope that the industry hasn't fully solved yet.
So to recap the American experience here, we have FDA gridlock, hospital billing conflicts, a legal vacuum, and an unresolved algorithmic bias problem. The U.S. healthcare system is entirely gridlocked by its own legacy architecture.
It's a mess.
It really is. But while we are stuck arguing over billing codes, there is a wild global paradox happening. The Path and Gates Foundation put out a study in 2025 that completely flips the narrative. Innovation is flowing like water. It's just finding the path of least resistance.
The global paradox is staggering. While the U.S. system paralyzes itself, regions like rural Kenya and Nigeria are deploying this advanced AI technology right now.
Because the math on their healthcare infrastructure is totally different.
Entirely different. In those regions, you are looking at a ratio of perhaps 2 physicians for an entire region of 100,000 people.
2 doctors for 100,000 people.
Yeah. They do not have the luxury of debating whether an AI should be relegated to a second opinion or worrying about cannibalizing specialty billing.
There are no specialists to cannibalize.
Exactly. In the U.S., AI is blocked because it threatens legacy bureaucracy. In rural Africa, nurses equipped with basic tablets are using large language models for primary diagnosis because the AI is the only specialist available.
That's incredible.
It is. The lack of legacy infrastructure is actually their greatest advantage. The world's poorest countries are adopting the most advanced medical technology significantly faster than the richest nations.
Necessity really is the ultimate driver of adoption. But let's bring this back home to you, the listener listening to this right now. You are likely navigating the gridlocked fee-for-service system we just described.
Right. You're stuck in the middle of it.
You don't have access to the hospital's internal AI, but you do have access to commercial large language models on your phone. And the Washington Post and NPR compiled a pragmatist's guide in 2026 for how everyday patients are using AI to navigate their own care.
It's a really useful framework.
So what does this all mean? How do you actually use this intel practically for your appointment next Tuesday?
Well, the guide outlines very specific parameters for safely using commercial AI in a medical context. Let's start with the highly recommended actions. You absolutely should use an LLM as a medical translator.
Yes, translation is huge.
When a dense, terrifying 14-page pathology report hits your patient portal at 9 p.m. on a Friday and you can't reach your doctor, feed the text into an AI. Ask it to explain the findings in plain English.
It just takes the panic out of the jargon.
Exactly.
Yeah.
You should also use it to prepare for your visit. Human doctors have incredibly limited time.
Usually like 15 minutes if you're lucky.
Right. If you use an AI to organize your scattered symptoms, timelines, and family history into a concise, structured medical summary, you are empowering your doctor to do their job faster and more accurately.
But the guy is equally strict about the don'ts. The absolute worst thing you can do is ask an AI to diagnose a rare disease or an atypical cluster of symptoms.
Definitely do not do that.
The training data on rare conditions just isn't robust enough, and the model will confidently hallucinate a terrifying diagnosis.
Yeah, and you must also never trust it to evaluate complex drug interactions.
Oh, that's a big one.
If an elderly patient is on 12 different medications managed by 3 different specialists, the chemical interplay is just too volatile for a commercial chatbot to safely manage.
It's too risky.
Way too risky. And under no circumstances should it be used for psychiatric advice, where the nuance of human emotion and the risk of harmful guidance is extremely high.
So it all boils down to the golden rule repeated across all these clinical dossiers. Use AI to prepare before the visit. Use it to translate the jargon after the visit, but never ever use it instead of the visit.
Right. It is your personal medical interpreter, not your primary care physician.
Because the human element, the physical examination, and the clinical intuition of a seasoned doctor cannot be entirely replaced by vector embeddings.
Not entirely, no.
So stepping back and looking at the entire landscape we've mapped out today, the fundamental truth is that the technological cure for a massive systemic vulnerability has arrived. We know how to drastically reduce the 800,000 diagnostic casualties happening every year.
The math is there.
The Harvard trials prove the math works. The dirty data proves the tech is resilient. But the American healthcare system is actively rejecting the cure because of structural rot.
And across all the internal strategic assessments we reviewed, there is only one viable systemic escape hatch mentioned. The only way this technology gets adopted in the U.S. is if the system completes a massive shift toward value-based care.
Moving away from the fee-for-service treadmill.
Exactly. Value-based care flips the financial model entirely. Instead of billing for volume and individual tests, hospitals are paid a set amount to keep a patient healthy.
So they are billed on outcomes.
Right. In that model, an exact early AI diagnosis isn't a revenue killer. It actually becomes the most profitable tool in the building because it prevents expensive downstream hospitalizations.
That makes total sense.
Until those financial incentives align, the technology will remain locked out of the exam room.
But we need to leave you with one final sobering piece of intel from the dossiers. It is the ultimate dark irony of this entire paradox. While your doctors are legally and financially blocked from using AI to read your medical files to catch a tumor and save your life, the algorithms are already deeply embedded inside the healthcare system.
They're just being utilized by the opposing side of the industry.
Major health insurance companies like United Health, Cigna, Humana, they have already deployed highly sophisticated algorithms at scale, but they aren't using them to synthesize dirty data and find a cure.
No, not at all.
They are using them to automatically mass deny patient claims. They're using AI to instantly reject prior authorizations for treatments your human doctor requested, processing thousands of denials a minute.
It's chilling.
The technology is already here. It works perfectly. It is just currently working against you, not for you.
It really forces us to ask who truly gets to leverage the power of efficiency in a profit-driven system.
It really does. Thank you for joining us on this deep dive into the source material. The next time you are looking at a medical scan or sitting in that waiting room, remember that the illusion of the clean, simple diagnostic process is just that, an illusion.
The reality is messy.
The data is dirty, and the system is fighting the very tools that could finally help us see clearly. Use the tech to empower yourself, and until next time, keep questioning the system.